Good afternoon to the two people that have joined us. I'm just trying to, I'm going to welcome you by name, I think. So we've got Sam Cook and there was somebody else, I thought, Sarah Hunt. So pleased to welcome you. The rest of us on the call are from the NHS. So if we're in a room, I think you'd be a bit overwhelmed, but we're not. We're in a virtual room. So it's really good to see you joining us today. My name's Caroline Trevithick. I'm the Director of Nursing Quality and Performance for the Leicester, Leicestershire and Rutland Clinical Commissioning Groups. And I'm going to chair today, but actually it's going to feel like a bit of a conversation if there's just the two of you, if no one else joins. The format of today is that we're going to show you a video of the plans that we're consulting on around the hospitals in Leicester, and then it's over to you for question and answer. So we'll close the video down so that we can see each other properly, and be able to pop your hand up and then have a conversation with us. So over to you then, Joe. If you play the video for us, that's great.
We want to spend £450 million to improve acute hospital and maternity services in Leicester, Leicestershire and Rutland. This means the services provided at the Leicester Royal Infirmary, Glenfield Hospital and the General Hospital. We want to see improved patient care, better patient outcomes and have staff working in the best place to make this happen. Most of all, we want to deliver hospital healthcare that is fit for the future. This is your chance to find out more about what is being proposed and to have your say. This will help your local NHS understand what the changes would mean for you and help us make a final decision.
What we don't want is a health service that's designed only by the people who work in it. It's got to be designed by the people who experience it and use those services.
The proposals include 2 super intensive care units, one at Leicester Royal and one at Glenfield Hospital, with 100 beds in total. That's almost double the current number. Modernised wards, operating theatres and imaging facilities. The first dedicated single-site children's hospital in the East Midlands, based at the Royal. And a new maternity hospital. Currently there are 2 units on different sites, the General and the Royal.
Obviously, having 2 sites means that sometimes we're spread too thinly. When we're really busy, when we haven't got enough rooms or when we haven't got enough staff to look after the women, especially in labour, women need one-to-one care. We have to transfer activity from one site to another. So we would envisage that with a new larger hospital where we pooled the staff together, that likelihood would happen less often. The beauty of it is that they're going to be in one unit, and if there is an emergency situation, they can very quickly have access to the obstetricians and the neonatologists.
Underall's Glenfield Hospital will become a major planned care treatment centre, with welcome centres to put you at ease and help you find your way around the hospital. These changes would enable us to separate emergency care and planned operations. This would help prevent treatment being delayed or cancelled when the emergency services are busy. More than 100,000 day case procedures and around 600,000 follow-up appointments take place every year at the city's hospitals. The move will free up capacity at the Leicester Royal Infirmary and help ease issues of access and parking there.
Let's take a patient, for example, who's having a planned day case surgical procedure. They will receive their pre-operative workup on this site, so all the tests and things they need doing before the operation. They will have also been seen in clinic on this site to have the decision made that they need an operation in the first place. Then they'll come to this site, they'll have their operation and go home the same day, and any follow-up that's necessary after that will also be provided on this site.
Leicester General Hospital will become a community health campus. It would include facilities such as the Diabetes Centre of Excellence, a dedicated imaging hub to help GPs diagnose patients' conditions quicker, and a stroke recovery service with inpatient beds. It would potentially be home to a midwifery-led unit, which will be relocated from St Mary's in Melton Mowbray. This will make it accessible to more people and provide a better and safer experience for mums. Today's modern medicine and technology means many patients don't always need to stay in hospital to get well.
Over the last 30 years, the NHS has cut its beds by about 50%, which feels counterintuitive looking at the population growth. But when you take into consideration the change in medical practice over 30 years, so hip replacements used to come in and be in hospital for over a week. They're now staying in hospital for around 2 days. We've got sort of robotic surgery now and keyhole surgery, which means patients don't stay in hospital as long. And we used to prescribe bed rest for patients. We don't do that anymore either.
And for some conditions, you can be cared for at home or where you live.
If you need to be in hospital, so you need treatment or you need investigations that can't be done in the community, or, for instance, you're acutely unwell and you need the investigations doing straight away, hospital is the right place for patients. But there's where then medical treatment can happen at home. And it's much nicer for the patient if you can have all the care investigations done in your own surroundings, done at local community hospitals with doctors, nurses coming in that will be the same faces that they see on a daily basis. It's about having safe care, but in the best way for the patient, the most suitable way.
At the moment, our hospitals and our staff, while doing their best, are spread too thinly, trying to provide 21st century services in outdated buildings with limited resources and opportunities for change. We want to achieve a service based on our future healthcare needs, not the legacy of the past.
Leicester's hospitals merged in 2000, and whilst that merger was very successful, it left one issue unresolved. And that was that many of our clinical services, the location of those clinical services is more a product of accident than design. They're split across more than one site. Our staff are spread thinly and our equipment isn't always in the right place. And that can lead to difficulties with staffing our services in the way that we would want to do optimally. I'm really excited by these changes. I think that this is a once-in-a-generation chance to provide care in Leicester, Leicestershire and Rutland that will be state-of-the-art, will give patients a much improved patient experience, give them access to modern medicines, modern treatments in modern buildings. And I'm really excited by this, and I hope that people will be when they see the plans of what we're planning to try and do for Leicester, Leicestershire and Rutland.
You can see the proposals on our website and fill in a questionnaire to give us your views.
Okay, thank you, Joe. Right, I think we're going to close down the visuals now. Welcome to Fiona Francis and Jeffrey Smith for joining us. I introduced myself earlier, but I'll do it again. I'm Caroline Trevivick. I'm the Executive Director of Nursing Quality and Performance for the CCGs in Leicestershire. I've got some colleagues with me from the Trust. I've got Andrew Furlong, Medical Director, who you saw on the video, Ian Scudamore, Consultant Obstetrician, Elaine Broughton, who's Head of Midwifery, and Darren Kerr, who's the Director of Estates. So we've got a few of us here to be able to answer questions around the specifics, but we've also got a really good team from our comms team if there's anything that anybody wants to ask about the process of consultation. If we can use the hands up mechanism, if anybody wants to ask a question, or if anyone wants to pop it in the chat, so we can have a read of it while we're thinking. But we really do want to hear from you rather than have us talking all afternoon. So has anybody got a question that they'd like to put to us, to any of us? Silence. Joe, can we get rid of the picture? I just wonder. Yeah, somebody's got their hand up. Right, let's find out who that is. So Sarah Hunt, welcome.
Hi there.
Hello.
I was just wondering if the plans have changed any through the COVID experience. If you're looking to change anything, or whether you think the process and the things that you've put in place still sort of apply now that something like COVID has happened.
Absolutely, that's a really, really good question, Sarah. I think I'm going to look to Andrew to answer that.
Yeah, it's a great question, Sarah. I'm Andrew Furlong. I'm Medical Director here at UHL. And You're right. I mean, the plans have been developed over a number of years to get to where they were. And with COVID, it was only right and proper that we did look at the plans and make sure that they still met the criteria in terms of what we've learned from COVID, and largely they do. And I'll tell you why. So during COVID, at our peak, we got to about I think it was 56 patients on our intensive care unit with COVID, but meaning that there were about 70 patients at any one time on our intensive care units. We currently have 49 commissioned intensive care beds. This plan will take us up to 100 intensive care beds, so we would have had plenty of capacity and more to manage both the patients within LLR who needed intensive care beds for COVID, but also would have meant we would have been able to provide mutual aid to other hospitals around us if their services were starting to become overwhelmed. Also, during the first COVID, because of the need to create additional intensive care capacity, that meant that we had to start to use our operating theatres. We had to move our children's services from our paediatric intensive care unit at the Glenfield, and that meant that our children's heart services had to temporarily be transferred to Birmingham. Now, and nationally, what was seen was that was quite a common thing that needed to happen. Adult services needed to move into children's services, and children were quite significantly affected by the effects of COVID on adults, whereas the disease in children, as I'm sure you're aware, for most children is a relatively mild thing. And those areas those children's services that did best were where they had a standalone children's hospital, because they were able to continue on with that work. So again, if we'd have had enacted these plans before COVID, would have been able to keep our children's work going. The other thing that we found is that those centres, those hospitals that have got a relatively contained facility, such as a treatment centre, were able to keep some of their elective services going because they were able to create what are called clean pathways, green pathways. And one of a key plank to our strategy is to try and separate as much as clinically safe to do elective services from emergency services. And the treatment centre that we're proposing to build at the Glenfield is a substantial building that increases the footprint of the Glenfield by about a third, and would mean that we would have separate facilities that would have meant that we would have been able to keep some of the elective work going that we regrettably had to stop in the first wave. Alongside that, the new wards and operating theatres will have far better layouts than our current very aged wards in some cases, which means that there's better separation between the beds. They'd have better ventilation, which means that they'd be much more appropriate for managing pandemic viral type illnesses. But of course, the other thing that we've looked at following COVID is we've looked at things like, have we got enough single rooms in our plans? Do we need to think again about the layouts of our intensive care units? And all of that has been built into our thinking. So I think what we have learned from COVID is that we probably do need to increase the provision of single side rooms with ensuite facilities. And what the plans are now moving to is looking at, rather than having 30% side rooms in a new build, we're looking to probably take that up to about 71% in the new build wards and areas. But still 50% on the intensive care units, because that allows the flexibility with intensive care. Yeah, so a great question, and yes, we have looked at that. Thankfully, the plans stand the test of a COVID pandemic, but we are tweaking them based on the learning that we've had from the first wave of COVID and the current wave of COVID that we're in.
Thanks, Andrew. I know Ian Scudamore just wants to cover it from a maternity perspective as well.
Yeah, I think it's a really excellent question, Sarah, isn't it?
Yeah. Yeah.
And interestingly, with the 2 units that we've got at the moment, what we had to do with maternity services at the beginning of the pandemic was create separate physical pathways for care for those patients, those women that we thought were liable to be COVID positive or confirmed COVID positive, and those that weren't. And that was extremely difficult because of the estate on the 2 sites, and that's not easily changed. So the issue around COVID now for us, I mean, we're doing the best we can, and we've managed to do that to a very large degree to keep the 2 groups of patients safe. But it's going to be what happens with another pandemic another time, because it looks as though we will get on top of COVID at some point in the next 12 to 18 months. And of course, we're looking at plans for 4 or 5 years time from now. So the big advantage of what we're planning to do is that we're going to have a dedicated maternity hospital. So we won't have medical patients in that building. We'll only have maternity patients in that building, with the exception of an intensive care floor, which will be completely separate from the maternity services. And we can build it in such a way that we can build in the ability to create 2 separate physical pathways, so that if and when, as there is very likely to be another similar kind of pandemic situation, we can switch into it really easily and really quickly and much more effectively. So in some ways, it's been quite useful to have the COVID pandemic, because it's allowed us to look at the building and build in that sort of specification in the longer term, and not get caught out in 10 years' time.
Sarah, the other thing that we've been thinking about is not just COVID. So we know that there are other things that will come down the line. So increasingly, we're seeing antibiotic resistance and organisms called extremely drug resistant organisms, particularly with our population, where we've got a large population of people who travel to the Southeast Asian continent, but not just there. There are lots of areas in Europe now that have organisms and bugs where there is a lot of drug resistance. And so things like having more side rooms, making sure that you have buildings that meet modern specifications for hospitals with larger spaces and better wayfaring through them, so that you can have single flow and almost single direction of traffic through them, and that sort of thing, are all things that will support better infection prevention, not just for COVID, but lots of other organisms as well, and lots of other potential threats that we face in the years to come.
Thank you.
Thanks, Sarah. I think it's probably fair to say that COVID has proved a good test of our plans to be able to think about it going forward. But really appreciate your question. Welcome to, we've got a couple of others joined us. We've had a video. I'm conscious that you won't have seen the video, but the video is available on our website to view if you want to do that after we've met. But we're asking for people to pop their hands up for questions, or pop something in the meeting chat. Is there anything anybody else would like to cover? Oh, Jeffrey, hi. Please, good to see you.
Yes, I'm wondering when, if ever, we're going to get booklets that we were promised to be delivered to our doors. Now, we are 1 month away from the end of the consultation. I think we're running it a bit close in terms of being fair to people who like to read rather than look at screens. Thank you.
Thank you, Jeffrey. Good to see you, by the way. In terms of the, we've actually done a leaflet drop. It's not a booklet that we've been putting through doors. And I'm going to bring Sue in just to go through the detail, because we've done 2 leaflet drops and in quite a number of households. But I think one of the challenges with leaflet drops is that it gets, when you get, I know what I'm like, when I get a pack of junk mail through the door, I just pick it up in a batch and pop it into the recycling. So we're really conscious that people haven't seen it. You know, we are getting feedback that the people haven't seen it. But we have absolutely done it. Sue, do you want to come in and just cover the details of exactly what we did with that leaflet drop?
Yeah, certainly, Caroline. Hi, Jeff. Lovely to see you and hear you. I hope you're keeping well. Yeah, we have, as Caroline said, we've done a couple of leaflet drops, and just as Caroline's explained, it definitely isn't a science on this. The second door drop we have done with GPS tracking in terms of being able to monitor information into people's homes. So if there's any feedback that you want to direct directly to me, because I know you've got my email address. But I think the important thing to say is that the leaflet drop is just one small element of a very extensive campaign that we've undertaken throughout the whole of the consultation process, and that has included quite extensive digital engagement, including things like TV advertising, and supported through work with newspapers and community and commercial radio stations as well, and that goes across the whole of Leicester, Leicestershire and Rutland. Traditional methods, because we're absolutely aware that not everybody has got digital capabilities or just wants to engage in that way. So we have been hitting the pavements ourselves and getting out and about, and where we've been able to, leaving posters, and where possible also leaflets. Obviously there have been some restrictions with that around the COVID period of time. We've also contracted with approximately 19 organisations, the majority voluntary and community organisations, but some social entities out there who have got much better reach with individual communities, particularly those with protected characteristics, and they've been really working closely with those organisations and holding individual events themselves and doing a lot of activity, particularly in the city. One of our key partners doing a tremendous amount of work is also the Council of Faiths, who've really been working hard to deliver direct messages to, particularly via individual faith groups. Traditional methods as well through our district and parish councils have also been working well. And in fact, last week we held an event with parish council clerks and key parish councillors, and they're really working hard to support us. And also, and I know this is something close to your heart as well, our PPG network have also been helping us. They've come on events, but we also just held a very sort of localized event to work through how those individual organizations can work through. But also they've been telling us the great work that they've been doing on a ground level and sharing that. So I think it's important that we look at the whole in terms of the activities that we've been doing. Thank you, Caroline.
Thanks, Sue. And thanks for the question, Jeffrey. So anybody else want to come in? Jeff, you still got your hand up. I'm presuming that's what oh yes, it's a legacy hand as we call it nowadays. Did you want to come back, or you're all right? You're on mute, Jeff.
Right, I'd like another question if I may.
Okay, yeah, sure.
And this is really about the problem that patients and visitors have in visiting Leicester's hospital. I know it's very difficult, and this is really addressed to Darren Kerr, and I know it's very difficult to put yourself in the shoes of people who try to come to the hospital. And one of the horrors is the long queue that you encounter if you come by car. If you think of coming in from the north, you come along and then there's a sign that says other patient parking, and you eventually turn round into the main road outside the Royal. And you then turn left and you go down Jerram Street and you go along Havelock Street and you get to the gate. Now, in the earlier engagement sessions, we saw plans that said, yes, there's going to be 2 gates and it's going to be... But it seems to me that this is a once-in-a-lifetime opportunity to sort out the Royal and to say there must be a better way of getting people in and out of that site. How do the plans fit in, and will there be another opportunity when the strategic outline case goes forward to do some real thinking with the City Council to get this right?
Thank you, Jeffrey. Darren, over to you then.
Yeah. Hi, Jeff. Car parking, you know, what can we say about car parking in the NHS? and access to some of the inner city sites, particularly. That I can't say anything that hasn't probably been said before, Jeff, or we might have talked about directly previously. But you're right, it is a challenge. It is always a challenge, and Havelock Street is a combination of challenge to do for us with technology that's on the existing car park there, which I'm pleased to say we will be addressing this year, but also the capacity in that car park at times, the particular speed at which we can get traffic through. So part of what we're planning to do, you're absolutely right about, was working collaboratively with the highways people and through Leicester City Council, will be, particularly if our plans, if our consultation goes through and we're successful, then the new maternity building will change the dynamic of our car parking a little bit, because we'll need more facilities for dropping people off at the front entrance there. We're looking to utilise the multi-storey car park more effectively. There's always a concern about too much traffic on Welford Road, particularly, and around that area. But we are working with highways, Jeff, and working through our travel planning to try and make access to our sites, particularly the Royal, easier in the future in terms of public transport as well. So people don't have to use the car. People don't have to come to the site with a car. So we're looking at working with them through a company called Go Travel, who have done some of this stuff really successfully previously, to try and increase the accessibility to the site and the wayfinding once you actually get there, and even looking at when you park, how easily is it for you to get from the car park to the different buildings. So it's a sort of blended solution of everything, Jeff. We're not going to solve car parking overnight. Nobody is, because there is never enough car parking to go around for everyone. That's just a reality. But I think I'm quite proud of how much effort we put into car parking in Leicester. Certainly, we try and create a lot more car parks and a lot of accessibility than some inner city sites that I've worked in previously, where we think we've got our challenges. Theirs are even worse. But it's again another really good question. Something we're very conscious of. Hopefully, through this whole programme, it'll give us a chance to change the car parking and the accessibility, particularly Dean and none of us. The first thing I noticed when I joined the trust was just how bad it was on Havelock Street, and I spoke to John at the time what we're going to do about it. He said, well, we'll have to build a multi-storey car park, which we did, and that has helped. But Andrew referred to the ageing estate and the ageing buildings. It isn't just the buildings, it's some of our other infrastructure, like car parks. We need to change those and bring them up to speed with things like, automatic number plate recognition and these other technologies, which should just help us get flow through the car park a lot better.
Thanks, Darren. Andrew, I think you want to come in as well.
Yeah, thank you. Thanks, Jeff, for the question, and lovely to see you. I think the other thing that's worth noting is that through the plans in terms of the way that the services move around that we want to consult, or that we're consulting on, and the treatment centre, that the initial modelling shows that the footfall across the Leicester Royal Infirmary site will reduce by about 45%. So actually, there'll be a significant shift of things like outpatient and day case activity away from the Leicester Royal Infirmary site, which will decongest that site significantly as well. So I think that will also play into the sorts of things that Darren was talking about.
Okay, thanks for that additional point. Right, I think we've got Jean Burbridge. You put your hand up. Welcome.
Hi. Hello, can you hear me?
We can, yes.
Oh yes. Yes, I'd like to ask a few questions, but I mean, I'm afraid I would like to disagree on one point to start with, that the leaflet drop has been very unsuccessful as far as I can tell, because we keep asking people if they've had one, and very few people seem to have had one. And it'd be a shame if there's been a waste of money printing them and they're not being distributed. However, could I ask a few questions? I'm very interested in the planned care centre at Glenfield. I've seen it referred to in terms of being a new hospital at times. I've also heard it said that it will increase the size of the Glenfield by a third. And another time I heard it being said that it would increase the size of the Glenfield by half. So I haven't had the time to go into the pre-consultation business case to find out all the answers to these questions. So perhaps you could tell me, the planned care treatment centres, I think I read how many theatres there will be, but I've forgotten. So can you tell me how many new theatres will there be? Where will they be? And can you explain what are all these planned care treatments that are going to be in this if it is still 7-storey block? Because often when people talk about planned care, they tend to think about things like knee and hip replacement, things that are sort of very, very planned, and you almost get the feeling that they're at the end of the list, and perhaps they're the first things to be cancelled. There's this sort of feeling that maybe the medical people think they're not as necessary as other things. But friends I know have had hysterectomies. Are they planned care? Friends I know have had collapsed bladders and had to wait. So is that planned care? So it's all those questions about what you mean by planned care treatment. The other problem I have is that when I first heard about it, which was back in March 2018, I think, I got the impression that these, instead of having beds, you were having chairs. They talk about day cases. Now, I know what an outpatient thing is. You go in and you have a quick procedure and you go out. That's outpatient. What are these day cases? I had the vision of people sort of being thrown out in the middle of the night because they could only stay 24 hours. So I have all this confusion, and I'd love to know what the planned care treatment centre involves.
Thank you for that, Jean. Andrew, I think that's probably best place for you to talk through.
Yeah, very happy to talk through that. Yeah. And there's quite a lot of detail in there, Jean, and I'll try and go through things in broadly. But so if I start with the building itself, so I think at the key point is that it's a substantial building on the Glenfield site, and I have heard people refer to it as a new hospital. I think the reason it's referred to in that way is that it's essentially it will be a building on the front of what is the current Glenfield estate at the front there, and it will be separated but linked. And that's deliberate in the sense that, as we talked about, what we're trying to do is separate emergency urgent care from planned care, because as you've said, that, and I'm an orthopedic surgeon, so great that you're making the case for hips and knees. But as you've said, that the people like that, people who are waiting for sort of less urgent things in terms of they're not cancer or they're not life-threatening, sometimes get their operations cancelled. Doesn't mean to say they're any less needing in terms of their operation, but sometimes when it's life-threatening or limb-threatening, then those are the things that will obviously take priority. So that's what we mean now, and the actual size of it is work that we're continuing to do at the moment, because we need to, again, it links back to Sarah's question about responding to COVID. So one of the things that's changed around COVID is that we're doing much more outpatient work virtually. So like using these sorts of technology or using telephones. So actually we are doing some thinking about what is the right size for our outpatients, because since March now, about 20% of all new outpatient appointments are done virtually, and about 50% of all follow-up appointments are being done virtually, either by telephone or video consultation. So clearly, if you're using that sort of technology, you don't necessarily need quite as many outpatient rooms or traditional outpatient rooms in your new treatment centre as you might have done. But equally, what we might need is more within that building. We might need more sort of video type consultations where we've got rooms that are maybe not quite as big as a traditional outpatient setting, because you don't necessarily need the couches and some of the other equipment, but we need really good IT with double screens and cameras and that sort of thing, so that we've got good AV. So these are the sorts of things that we're thinking about at the moment, which will affect the size of the building. But I think that the point to take home is that this is a substantial new build. And the reason that it's 7 stories is because it's going to have things in it such as most of our outpatient services, a lot of our day case surgery, and I'll come back to what day case surgery is in a second, also something called 23-hour surgery. But in addition to that, some of the inpatient services that we're moving to the Glenfield will require new operating theatres and new wards, and it's actually easier to put that all in one building rather than build lots of different buildings. So the reason that it's 7 stories is that, you know, maybe the first 2 to 3 stories will be our outpatients and our day case 23 hours facilities, but the rest of it will be some of the inpatient facilities and the theatres that we need to build to support some of the inpatient services that will move to the Glenfield. In terms of what is day case surgery, well, that's a fairly established concept these days. So essentially that would usually mean that you would come in to a receiving facility in the morning or in the afternoon, because often you'll run 2 sessions through a day. You would come in, you would have a procedure such as typical day case procedure from my specialty would be a knee arthroscopy, so keyhole camera surgery done through small incisions to the front of the knee. That operation can often be done under local anaesthetic these days, but does require you to go into a clean environment, such as an operating theatre. So that's what we would mean by day case surgery. You would then usually be recovered and go home, usually around, if you're done in the morning, you may go home in the afternoon. If you're done in the afternoon, you may go home early evening. Now, what we are also wanting to do is to develop 23-hour surgery, which means that you would potentially come in the morning and go home the following morning. So it's almost like a one-night stay in hospital. So
it would be a stay overnight.
So for 23-hour surgery, that would involve a stay overnight. So there would be a combination in that facility of beds and couches, because for some people who are having a day case procedure, essentially they just need to recover from what is often a fairly light anaesthetic, that has used a combination of local anaesthetic blocks, and so they don't need a traditional bed to recover in the same way. And the danger of having traditional beds is that you then treat people, then people stay in hospital when they don't need to stay in hospital. And that's not necessarily good for people sometimes when they're having day case procedures. So that's the sort of facility that we're talking about. In terms of what is planned care, well, essentially it's the clue is in the name. It's anything that is relatively planned and that you can wait a period of time to have, as opposed to urgent or emergency care, which is often the sorts of things that you come in urgently or as an emergency to have done. Such as, you know, if you had appendicitis, you would come in as an emergency. But if you were, and you needed to be in hospital, but if you were having another type of bowel surgery, that might come in as a planned procedure. So there will be lots of examples of what's planned and what's urgent, and something that's planned can become urgent, and sometimes even urgent things can be done in a relatively planned way. So that's where it gets slightly blurred. But I think essentially it's the sorts of things like your hips and knee replacements would be planned operations, versus if you had a broken bone, that would be an urgent operation. Does that answer the question?
Yes, thank you. Can I ask a few more? I'm not sure who the chair is. Is it?
I'm chair. Yes, absolutely, Jean. Yes, if you've got some more questions. I
am glad that Leicester can have some new facilities, and really hope it's going to work. But when you mention again this sort of couches or beds, because of my age, I'm not going to tell you what it is, but most of my friends are suffering from complaints that come when you get older, shall I put it. I also have a lot of friends that live on their own, and if they went in for anything that requires anaesthetic, they're going to have problems when they go home. So they won't be able to go home and look after themselves. And I think, as Sue Venables knows, I've taken great interest in what the Community Services Review covers, and that's still a bit, well, it's not been revealed because it's not been finished. But I have this huge worry that a lot of this hospital reconfiguration plan, as it says in it, is relying on there being good, adequate community services. And that surely will still include community hospital beds and places where people can go after they've had their 23-hour or day case operation, or any other type of operation where they've been in hospital for several days but still aren't really capable of looking after themselves at home. So, I mean, I know Ian can't tell me about, sorry, Andrew, can't tell me about community services, because that's not his brief. But I do find that that is a bit of a worry, and it's throughout the plan, isn't it, that you're wanting to decrease the length of stay in hospital and rely on technology like keyhole surgery for people to have quicker operations, go home quicker. But surely there's going to be a time when you reach the limit, and after that time, as the population, especially the aged population, increases, you're going to need more, and here's the dreaded word, beds. And I
might have a go at responding to some of that, Jean, because what we know about the way people recover is that that we know that home is the best place. So what we want to do is we want to build hospitals that are big enough, but and if Mark Whiteman was here, he would say they're big enough, but just big enough. The key to this is getting those community services appropriate. For the majority of people who come into our day case procedures, they go in, have their procedure, go home. But for some patients, they do need some additional care and support afterwards. And so those patients will be looked at on an individual basis to see what that care requirement is. And what we're not saying here is that because we're focusing on day cases and 23-hour stays, we're not pushing people out to the community in an unsafe way. We want to make sure that it's still done safely, that there's still the wraparound support at home, either from family or, if required, from community services. So the consultation that we're doing around the changes to the hospital sits in a much broader plan as to what we're doing to resolve some of these deep-seated issues that we've had in our in healthcare in Leicestershire for some time, and i.e. that is the fact that we've got too many people going into hospital, staying too long because we haven't got the services to be able to pull them out of hospital quickly enough. So the context of that wider plan that we're working on is to make sure that we've got the resource in the right place to be able to support people to be at home, because home is where we recover better. Being in hospital surrounded by other people who aren't COVID has given us that in spades, really. But being surrounded by people who aren't the normal people that you would normally be around potentially increases your risk of getting something else whilst you're in hospital. So if we can be at home, that's the focus. And you will have heard us use some of the terminology around home first. So we want to be able to keep people at home for longer. And the consultation is about making sure that the hospital is the size that it needs to be. You talked about the fact that the community service review is still kind of under wraps. The main reason for that is we're doing exactly what Sarah asked us right at the beginning. What is the learning from COVID? So we're looking at the learning from COVID on the community hospital estate to make sure that we're not going forward with our plans without thinking about it in the context of COVID.
Jean, it's probably also worth noting that I qualified as a doctor in 1989. And my first house job, when they used to be called house jobs when you first qualified, was I worked on a surgical ward, and that ward was hips and knees, and then I worked on a ward which did gallbladder surgery. And in both of those wards, patients used to come in the day before their operation. For a hip replacement, they used to stay 2 weeks. And for a gallbladder operation, that used to be done with a big cut onto the abdomen. And again, people would stay for 2 weeks. We know now, and there's been huge advances in medicine since that time. So the average length of stay for someone having a total hip replacement or knee replacement now is 2.5 days. And people don't come in the day before. And there are, for those patients who are very fit or medically optimized, there is even hip and knee replacements being done as with a 24-hour length of stay now. And there is lots of evidence that shows that the outcomes of those patients are better than the patients who stay longer. The same with gallbladder surgery. So most of that surgery is done laparoscopically now, as through keyhole surgery. and that's done as a day case procedure or at most a 24-hour stay. And again, the outcomes are as good or better than what used to happen. We've also got things like robotic surgery now that means that we can do much bigger operations with much less morbidity afterwards, so patients can recover much more quickly. So I think essentially what we're talking about building is modern facilities to provide modern healthcare. We also know that because of the way that some of our buildings are structured, that we're not where we should be in terms of things like the number of day case procedures. So we have people who stay overnight for knee arthroscopies or hand surgery or things because of the way that our theatres and our buildings are structured when they don't really need to be in hospital. But equally, these plans do result in a 7% increase in our inpatient beds as well. So we are building for both, but I think what we're trying to build for is modern healthcare using modern techniques.
Thanks, Andrew. I think, Ian, you wanted to come in as well to respond to Jean.
Yeah, I just wanted to support Andrew really, just with a personal anecdote, insofar as until about 5 years ago, having been in practice as an obstetrician and gynecologist for 30 years or so, of which 18 at that time was as a consultant, I was doing probably all of my hysterectomies as open operations. And women came in on Thursday, went home on Sunday or Monday, and it took them perhaps maybe 3 months to get back to normal. And when I say normal, I mean completely normal. Now I'm doing 90% of my hysterectomies using a keyhole technique. 90% of those women I operate on a Thursday afternoon, and they want to go home and do go home by lunchtime on Friday. And they're back to work and back to normal activities in 6 weeks. So that just emphasises what Andrew was saying from my own personal practice.
Thanks, Ian. Okay, I think I've got somebody else with a hand up. I'm just looking in terms of Sarah. Sarah, you've got your hand up. But Jean, is there anything else you wanted to ask before I move on to Sarah?
Can I come back later then if there's time?
Yeah, certainly. Yeah. So we'll come to Sarah then.
I'll take my hand down.
Okay.
Hiya. I just wondered what sort of plans have been put in place for maintaining patient pathways through the transition phase, through the actual build.
Okay, yeah, it's Andrew coming in there.
Yeah, so Darren may want to come in as well, but it's a great question because we're going to be building buildings and moving services around while still trying to keep services going, and so that there is a very detailed plan around that, and Darren may want to come in with a bit more of the detail, but essentially the plan at a very high level, the plan, so once we get the final approval on the plans, the plan will involve some demolition to create space for the new buildings that need to be built, and the two major new buildings that will need to be built is the Women's Hospital at the Leicester Royal Infirmary and the treatment centre at the Glenfield. That will then allow, once those are built, that will then allow us to start to move the services into those new buildings, which then frees up space to start to do the conversion of the buildings that are left behind. And the big one there is the Kensington building at the Leicester Royal Infirmary, where maternity services currently are sited, will become the new children's hospital, standalone children's hospital on the Leicester Royal Infirmary site. So that will then, once the children's services, so maternity services move into the new building, then we can start to do the work on the children's buildings. And then once the children's buildings are built, that means the children's services that are currently in the Windsor and Victoria, Windsor and Balmoral buildings, they can then move out of those, and we can then take those wards and convert those into adult wards. And so you can see that there's a sort of because we're not building a new building and then we all move in. This has got phases where things move along like this, and that means that the new buildings will probably, I think it's end of 24, early 25. Assuming that we go as the plan is currently phased, would be available, and then that the whole thing wouldn't necessarily be done with a fair wind and the start date that we're till 2027 or early 28. So there's quite a long phasing in this because of the fact that we're not building a new building and then just moving into it. It's a series of moves that have to take place to keep, and also an aspect Darren will want to talk about, you know, how do you keep access to a site while you're doing all of these sorts of things. There's quite a lot to be factored into the planning. Yeah, absolutely. It's a great question. Darren.
Yeah, really good question. And Sarah, I'm really proud of the fact that our medical director can speak eloquently now about construction. So I've done my job, I think. That's really good. But yeah, it is a real challenge for us. It would be wonderful if everything I'd done in a past career was all about just building things on greenfield sites and building it all fresh and then just being able to transition things over. And it's unfortunately never that easy, Sarah, unfortunately. But Andrew's covered off most of the sequencing. As he said, what we've got to do, it's the way I always think, try and explain this to people, it's almost like having one of those Chinese puzzles, but before you've taken the square out the middle. And until you take the square out the middle, you can't actually start moving the blocks around, which is effectively what we'll be doing, what Andrew's just described, running through to the construction doesn't finish, as Andrew said, until 2026. So by the time we commission the buildings and everything, we'll probably move into 2027. But we do that by creating where we can decant space. And that means that some services, we'll endeavour to move services once, but some of our support areas and our staffing officers and others may need to move on more than one occasion until we actually create this wriggle room in our estate. But a lot of one of the key things is who the companies are we work with to do this construction. Because some of the big construction companies spend a lot of their time working in London. And you can imagine trying to build something in the middle of London where there's a really challenged network. So they have fantastic ways of doing that through comms, whereby almost on a daily basis, not just our staff, but public will get messages of what roads maybe have inhibited access, what we may need to close temporarily in terms of access within the hospital. And there's lots of new modern technologies out there that exist that help this, not just relying on new technology though, but also in the old-fashioned ways of dealing with this as well, in the sense of us recognising that not everybody has access to the internet, not everybody's familiar with a mobile phone in that level of detail, but lots of other communication vehicles. But we've got to create that decant space initially to be able to do it, and we do that by having a lot of again, I think Andrew covered it, in enabling schemes. And the enabling schemes, like the building that Jeff was asking about earlier, of our car parks and others, enable us to manage some of these service moves in as pragmatic a way as possible. And it's the one thing that, in fact, so I think the NHS is wonderful at lots of things, but the one thing we are also good at that is often overlooked is actually managing these kind of schemes in the middle of keeping a hospital live and keeping a hospital active. And that is a challenge for some of the companies, which is why it's important that we use companies who have familiarity with working within live hospital environments.
Thank you.
Thanks, Darren. Just struggling to take myself off mute there. Fiona, you put a couple of questions into the chat. Apologies, the chat wasn't working. It's all of a sudden come to life, so that's good. Did you want to ask them yourselves, or I'm happy to read them out for colleagues if they can't see them. Chat gets a bit tiny to read sometime, but yeah, okay, I'll read them out. So the first question is about the general, could it not be an option for the treatment unit and the maternity unit proposed? And what consultation have we done with residents in the east side of the city and the users at the general? So that's the first one. And then the second one being, how will you ensure that the buildings are inclusive in terms of religious and cultural needs? Have you worked with any BAME construction architects or taken advice from anyone in the BAME sector regarding construction? Darren, I think that second one's for you, but in terms of the general, Andrew, do you want to?
Yeah, I can cover off the first bit of that, and I guess the consultation bit, some of the comms team might want to comment on that bit. So it's a good question, Fiona. Some great questions today. So I think probably the way to think about this is we need to take a step back, and I'll tell you where our thinking got to with this. So you may or may not be aware that Leicester's hospitals merged. There were originally three separate hospitals. Well, they are three separate hospitals, but they were run as separate hospitals: the Royal, the General, and the Glenfield prior to 2000. And that meant that they provided a lot of overlapping services because they were separate hospitals in their own right. And then the three hospitals merged in 2000 to become University Hospitals of Leicester. And that merger was very successful, but it hasn't addressed a fundamental, which is the fact that the services are not configured in a way that makes clinical sense to modern healthcare, and also means that that we have duplication and in some cases triplication of services, which means that both expensive equipment and our most important resource, staff, are spread too thinly at times across our services. And that has meant that things like our maternity services and our neonatal services, at times it's been very difficult to staff those in a way that is optimal in the way that we would want to. And it also means that when we've had people like the CQC come and look at our services, and the Royal Colleges, and things called peer reviews, that they have raised concerns about the sustainability of some of our services because they are split and fragmented. So part of what we want to do is to try and address this. Now, you'll also probably be aware that there was a big project called Pathway. When I came to the Trust in 2000, Pathway was still a live project, and there was a lot of talk about, when I came as a children's orthopaedic surgeon, there was going to be a separate children's hospital, and it was only a matter of time before I'd be working in that building. And Pathway, unfortunately, was canned in 2007, I think it was 2008, because it got close to £1 billion and was considered too expensive. And by that time, I was involved in reconfiguring some of the orthopaedic services which were split across 3 sites at that time. And we were trying to bring the elective orthopaedic services into one site because, it didn't make sense that we were splitting our services and it was very fragmented. And as part of that work, we built some new orthopaedic theatres and some new wards. But it created some capacity. You remember Darren talking about that Chinese puzzle? We had no space to start to move things around. So we then post the failure of Pathways, ran a series of large clinical workshops where we got all of the clinicians from all of the services, something like over 70 services that we provide, into series of workshops to think about, well, what's the clinical strategy then? Given that Pathways not worked, how should we configure our services both now and for the future? And if money had been no object, then overwhelmingly what the clinicians wanted was one hospital on a new greenfield site. If there was absolutely money was no object, because that would have addressed all of the things around clinical adjacencies and everything else. But we had to be cognizant of the fact that we'd just come out of something where it was getting to nearly £1 billion and had been considered far too expensive. So we realised that we had to be more pragmatic on that. On what we wanted and what we felt would make sense. And so we started to think about, as we talked about, how could we, where possible, start to separate planned and emergency care services where it made clinical sense to do that. And we also needed to think about critical care capacity, because one of the things that Leicester and Leicestershire and Rutland is massively underprovided for is critical care capacity. And we absolutely do not have enough of that. But we also need to know that the way that treatment is going, as I've talked about, is we can do much more, but that often means that the patients are sicker and need a period of time around their operation or around their acute illness with critical care facilities, and then are able to be stepped down into something else. So we also knew the direction of travel was that we were going to need more critical care beds in the future, not less. And we also, because we're a university teaching hospital, don't just serve Leicester, Leicestershire and Rutland, we serve the East Midlands, and in some cases we provide national services. And so the direction of travel for the very complex work is to bring it into big centres. So again, that told us that we needed more critical care capacity. So all of that then meant that we started to look at, well, how many sites do we need? What can we do to make sure that staffing is sustainable, given the things that the Royal Colleges and CQC were also telling us about our split services? And very quickly, it became clear that really we could only sustain clinically, and it made sense clinically, to have 2 acute sites. And once you've made that decision, then you've obviously got to make a decision about which are those 2 acute sites. And the Royal is by far and away the biggest of our 3 sites, and has our emergency services, our emergency department, etc., our children's services. And to re-provide that somewhere else would have been very, frankly, this is public money. We've got to try and spend it as responsibly as we can. Would have been hugely expensive and extremely disruptive to the services while we were doing it. So the Royal had to stay, and there was that was a unanimous clinical decision that needed to stay. So we were then looking at the general site versus the Glenfield site, and the reality of the estate on the general site is it is significantly older and less fit for purpose than the estate that we have at the Glenfield. And also the nature of some of the services that we have at the Glenfield, like our cardiac surgery services, our thoracic surgery services, mean that, again, if we were to re-provide that at the general, it would have been much more expensive to move the services from the general the services from the Glenfield to the general. So again, the decision was based on what clinical services that were already there, the estate, and also the fact that at the Glenfield, even moving the services we want, there is still a significant amount of land that is left for future developments. You could, after everything that we plan to do with these plans, there's still enough space left to essentially build another Leicester General Hospital. So there's significant land that's left on that site. So the decision therefore was that it was 2 sites for our acute services, where our intensive care units and our major inpatient work was the Glenfield and the Leicester Royal Infirmary. Now, once you've made that decision, then the difficulty with maternity services, and Ian may want to talk about this, is if you are running anything other than a standalone midwifery type led unit, you have to have on-site acute services for a maternity hospital. You have to have access to intensive care. You have to have access to general surgeons. You have to have access to physicians. And so therefore we couldn't put that at the general, because those facilities wouldn't have been at the general. So that meant that it wasn't safe or practical to put those services at the general. We did talk about whether to build a day case type facility, day case outpatient facility at the Leicester General. But again, because we wanted to do things more than just provide day case and outpatient facilities in a planned treatment centre, so we wanted to be able to offer 23-hour care. We wanted to, it became clear that actually it made sense to put that treatment centre next to one of our acute sites, because if patients did deteriorate, they needed to be rapidly able to move into the main building where those facilities were. So that was so essentially it was around clinical rationale. And our entire estate strategy is backed up by a clinical strategy. So it hasn't been, let's build the buildings and work out how we're going to put the service in. The building strategy is absolutely responding to the clinical strategy that has been developed by all of the clinicians who've been involved in that work over the last 10 years. And that was a very long answer, but hopefully you can understand it wasn't something that we just it wasn't an overnight decision. There's been a lot of work and thinking behind that.
And I think it's important to kind of get your point about the fact that the estate strategy is underpinned by clinical. That for me as a clinician, you kind of that's the right way to do it. Estate shouldn't drive clinical practice. Clinical practice should drive estate. So Darren, do you want to pick up the question about the design around cultural needs?
Yeah, absolutely. Albeit I might say, Caroline, of course, if I had my way, estate would rule the world. Of course it would, for obvious reasons. But you're absolutely right. They should be integrated together. They shouldn't be seamlessly integrated. Maybe just to contextualize the question a little bit, what I want to do is talk a little bit about this concept that we've got about utilizing this new strategy called social values, because when we talk about social values, that actually brings design into it. And what social values does, which is a requirement now, is it looks at issues around what does this 450 million investment mean, not just for UHL, but actually and LLR from a health perspective, but from a wider economy perspective to the city and the wider counties of Leicestershire and Rutland as well. And that looks at issues like employment, like environment, like What does it mean for the community? What does it mean for design of the buildings and the assets and our supply chains and so on? And what that actually means is that what we try and create from all of this is a legacy, really, a sustainable legacy from the buildings, which also bring in things like intergenerational benefits, bring in, absolutely a fit for purpose for diverse and inclusive cultures. We have, through all of our design processes, and not just the design, but our health planning, our broader health planning, a very comprehensive programme of involving all of our, what we think of as partners in this process, which is all of the members, all patient, all PBG groups, which have been mentioned a few times previously. Obviously focusing on some, we know there are some specific requirements for some of our groups around some of our BIM people, etc. And I think that's one of the real strengths that Leicester has is a richness in that area that we can tap into to be able to ensure that we recognise these things as we go forward with the build and the planning of our services. So, I think that is a really good question, again, really important. But it'll be not just within the design process, but it'll be with it across all facets of what we're planning to do throughout the whole delivery of this programme, very much built into this social values. We want to leave a legacy not just of great buildings. Obviously, I'd like to build nice new shiny buildings and things. Of course, that's my background. But we want this to be a legacy of improving the economy across LLR, as well as what we achieve for our patients, public and staff within UHL. So a really good question, something we will be taking very specific notice of, because we have that richness in Leicester, haven't we, of living in such a diverse culture. We'll have to take those things by necessity into account.
Okay, thank you, Darren. Really helpful response there. So do you want to just pick up on the question about what we've done with the residents in the east side of the city, for particularly focus on the general?
Yes, yeah. I mean, we're fortunate in terms of sort of marketing and promotional techniques that we've got, that you can get down to very sort of localized and targeted areas. So just looking at the sort of all the offline stuff, I mean, the traditional walking the streets and getting posters up is definitely there for us. But we've also engaged with both the individual ward areas, or if we're just going outside of the Leicester boundary, the individual parish council areas, and working with our county councillors, just to make sure the message is out there and they can spread that to their own parishioner areas. But also online, we've been able to do a tremendous amount with Facebook community groups, spotted groups as well, joining those groups and asking people to share information with their own individual communities. And also some of the other digital work that I was mentioning, like the Sky Television, that's very regional, but it's focused to very individual, almost postcode areas. So we can do some very targeted work there, and also working through patient groups and the practice patient participation groups as well, so that we can work in to get those messages. So we're continually working on that, and then the last sort of 4 weeks of the campaign will be doing more of that, and also those individual ward meetings to have those conversations in those very specific areas.
Thank you, Sue. I'd just add to that if Fiona, if you've got friends and family that live that side of the city, please advertise it yourself and point them in the direction of our website to be able to feed comments. We have comments from a really wide range of people. I'm not sure if anybody else has put a question in the chat, because I think we're having a bit of a problem with it. So if you have, I can't see it. So if you want to ask a question, then please pop your hand up. I'm going to look around and just see. Yes, Jean, you've got your hand back up. Yes, do you want to come back in? You did say. I think you're on mute, Jean. We can't hear you at the moment. Yeah.
Yeah, I'm sorry, I'm just going back to a similar point. Hopefully, if this all goes ahead as you plan, The building will be completed by what, 2024, 2027? I've lost my question. But my question is, how and where would you be able to expand after that? Because as I say, I've seen papers on the local plans that go up to 2034. Vast, big increase of population, and already Leicester and Leicestershire have got a lower sort of ratio of beds to patients than in other parts of the country. And so by 2034, if the national statistics are correct, we'll be very short of beds. And I've seen the bed bridge in the pre-consultation business case, and I understand how you worked out you'd need 300 more beds by 2024, but then you can mitigate so that you don't actually need 300 beds because you can, shorten stays in hospital, and then you can convert the Hampton suite to wards, and you can convert something else to wards. So I couldn't even find out how many actual new beds were in the plan, to be perfectly honest. So what contingency have you got for 2024 when there are queues outside the A&E because there's not enough beds in the hospital?
Okay, thank you, Jane. Great question again. It's got some fantastic questions this afternoon. It's really good. Darren, do you want to talk about how we're going to use our physical space, and then I can bring Andrew in about talking about bed numbers, if I may.
Yeah, absolutely. Really good question, Jane. You've obviously read the PCBC or been at an event where we've talked about the increase of 139 additional beds, even though the actual overall increase is 300. But then we talk about efficiencies within the system, and effectively talk about what will equate to 4 new wards worth of beds effectively. But Andrew will come back probably on how why we believe that satisfies our immediate requirement. Our building programme, as I said, doesn't actually finish until 2026, but what we're left with at the end at the Glenfield, Jean, is if I took all of the buildings that are at the General, for example, at the moment, which equate to just over 80,000 square metres, I would still have enough development space post all of this at the Glenfield to be able to lift that up and drop it into the Glenfield. What we've got left at the Glenfield post all of this is something in the region of 25 acres of space that we could still develop into. And that's just at a single story level. That's not going up. That's not putting the layers on. That's not building upwards, and which is obviously what we tend to do, so that we maximise the amount of green space that we've got. Because our whole concept of the 2 sites is to try and do that, because we know putting people into that type of environment is good for their health. And our concept at of our building programme at the Glenfield is about the hospital in the park, because we want to maintain as much of that green space as possible. But we would have enough. We'd have over 100,000 square metres of development space in the future. So we're not giving away the crown jewels. We've got enough space. It's more congested at the Royal. I think we'd all recognise that. But that doesn't mean that it isn't beyond the wit of man to say that we could possibly put further builds at the Royal. You just got to be somewhat a little bit more adventurous in your thinking around how we do that. But our main development site for the future going forward will be the Glenfield, and we've got space at the Glenfield to satisfy our future requirement. Andrew, Karen might want to come back on why we believe that our bed numbers give us that future proofing. I think we also recognise, I think Andrew said it earlier, again, which is great to hear about how we create flexible space within going forward, and how healthcare is changing over the time. And it's the same for our design standards. We've modified our design standards a lot, and will be, where we're using a lot of what we call repeatable rooms and standardized design, and this thing called modern methods of construction. So we're learning still from things like the COVID hospitals that we built, the Nightingale hospitals, how we try and create flexibility and flexible space in the future, which means that we can utilize that flexible space more effectively, so we don't end up with shortage of beds.
Thanks, Dan. Jean, I must commend you on your what was a very succinct and accurate summary of the bed bridge. So well, brilliant. I mean, you're right. So the plan assumes 3% growth, which equates in the time period that you talked about to 300 additional beds. Within that there's an element that's efficiency, and then there's an element which is building new beds. The efficiency plans are to equate to about 161 beds. Now that isn't just a number again that's plucked out of the air. That's been worked through with every one of our services, looking at where we sit against sort of national recognised standards around things. So again, we'll come back to day case procedures. There's something called the BADS group of surgeries, which is British Association of Day Case Surgery, in terms of where we sit in terms of each of the procedures that is usually done as a day case, and what percentage of our procedures are done as that, and understanding the reasons. And for some services, we're quite a long way away from those what are considered to be the norms of standard. And that isn't because our populations are sicker, it's because some of our processes aren't in the way they need to be, or our buildings don't support those processes. And we've done that with every one of our services, and the most conservative estimate of what that efficiency would be is 161. The most optimistic is up to about 240 beds. And this plan goes with the most conservative, which is 161. So there is potentially more that might be available in terms of efficiencies, but we've not assumed that in the plan. And that leaves a bulk of 139 beds, which is the expansion. And as you said, 28 of those are delivered through movement of the Hampton Suite, which is a rehabilitation type ward that exists within the Leicester Royal Infirmary, which is being moved out into the community. So that gives us 28 beds. And then roughly about 111 beds, which are new beds, which is either a combination of conversion of existing clinical space that isn't being used for clinical space anymore because it's being used as offices or those sorts of things, or new build, as Darren said, which is roughly about 4 wards worth of new. But there's more than 4 wards, newly wards being built, but that's what the overall increase in number is in terms of our existing bed stock. So we will be building more than 4 new wards, but the overall net effect, because we're moving from the Leicester General, is that the overall net effect increase is of 4 wards, plus that additional ones money. So about 139 new beds, which is 7% of our bed stock.
Sorry to interrupt.
Sure.
My ears heard community again. I did come to one of these consultation meetings, and I asked the question about where they were going to put the stroke beds from the general when they went into the Evington Centre. Wouldn't that mean that the Evington Centre would lose community beds? But actually, Sarah Prima said no, they're going to make office space into the new stroke beds. But when you say the 28 beds in Hampton, that's rehabilitation again, going into community. Where?
Well, it's already happened. That move we've already done that.
Oh, right.
It's been done.
Sorry.
Yeah. So that's 28 beds that we've already created as part of that plan. That's already happening.
Okay.
Where did they go? Is it spread out or?
Spread out. So it wasn't we didn't just pick up and put a ward somewhere else. They've gone across the whole of the LLR in terms of those 28 beds.
Thank you.
Thanks, Jean. Sarah, you've got your hand up. Thank you. You're on mute, Sarah.
Sorry. Is the IT infrastructure there to cope with this sort of developments and innovation across site visibility, or if not, what are the plans to put that in place? Okay,
Darren, is IT one for you?
Yeah, partly, but Andrew's our clinical lead on IT again, so I'm going to test his expertise. He's already proven his expertise today on construction and all things estate, so Andrew will be able to talk, Sarah, more eloquently than I can about some of the particular programs that we're currently developing through our IT strategy. And I won't steal his thunder about talking to us about being an IT aspirant. But it is again. There's some great questions today. It is a really key development area for us. And NHS Digit, we're working at the moment with an organisation called NHSX, NHS Digital. We've got some of their people working directly with us, along with our own programmes, which is Andrew can talk about more eloquently than I can, that we've got in-house about this digital passport programme to try and modernise healthcare. So in parallel with all of the stuff that we'll be doing, we'll be putting a lot of wireless technologies, a lot of new technology in, and in parallel with it, and a lot of new systems and processes in the NHS, and our buildings, making our buildings as much as we can digital proof going forward. It's an emerging area, Sarah, to be honest. So it would be wrong for me today to say that we're going to absolutely meet all of the aspirations out there, because I don't think anybody really knows what they all are at the moment. The central government are working on a number of programmes at the moment, and understanding what new buildings need to be digital proof is work in progress. But it's something we're working with them on, and we're working collaboratively. But as I say, Andrew can talk more about our digital aspirant programme, which is really exciting actually, and we're one of the few trusts in the country that's pathfinders in this. So that's putting Andrew on the spot.
Yeah, that's fine. That's fine. We'll have to talk about digital. How long you got? So before I came to Leicester in 2000, when I was appointed as a consultant, I spent a year doing a fellowship at a children's hospital in Toronto, the Sick Kids Hospital in Toronto, which is one of the sort of world-renowned units for children's orthopaedic surgery and children's surgery. And that was a modern, digitally enabled building. We were using electronic patient records. There was no paper. There was, it was digitally enabled. I was lucky enough to, about 6-8 years ago now, spend 6 weeks in the States as an exec fast track program, where again I visited lots of modern digitally enabled buildings in the States. IT was just second nature to them. And I think that this building program will give us an opportunity to develop buildings that are like that. But that we're not waiting for that. So we are developing electronic patient records at the moment. We've signed a 10-year deal with a company called Nerve Centre, which is developing our electronic patient record. And the beauty of that is that it's not an off-the-shelf one, so we are able to get that exactly as we want it to. And of all the IT that we've introduced over the years, it's the one that clinicians really like, and we've had the least amount of noise, and it works for clinicians because clinicians have been involved in designing it. We built our emergency department to be, initially the intention was to be a paper-free building, but it's paper light, and with Nerve Centre, we built the first ED electronic system, and that works really well, and that's what we're planning to roll out to the rest of the hospital through the work that we've done with Nerve Centre, and also with the system, because you may be aware that the system uses a system called System 1. So most of GP services, about 80-90% of them use System 1. The intention is that we will use Nerve Centre. The deal that we've done with Nerve Centre is that between System 1 and Nerve Centre, when a patient comes in from the community, System 1 will push information into Nerve Centre, and Nerve Centre will pull the information it needs out, so that you're not having to give information that's already available. We should know already. And when you leave hospital to go back into the community, Nerve Centre will push the information the other way, and System 1 will receive it. So there's lots of exciting things that the system is doing like that. And that the advantage of becoming an integrated care system is that we can drive those things as a system. We want our IT systems to talk to each other. And we're doing some really exciting stuff at the moment with Nerve Centre. So we're just piloting our new electronic prescribing system, which will be fully embedded into the Nerve Centre system. Now, at the moment, most electronic medical chart prescribing systems are standalone systems and don't talk to your patient record. The stuff that we're doing is fully mobile, it's fully integrated. So there's some really exciting stuff going on, which is why, as Darren said, we've been identified as a digital exemplar site. Now, there's supposed to be money coming with that. We haven't had the money yet, but there is money supposedly coming, which will hopefully speed up the pace at which we can do these things. But we've got really strong aspirations in terms of where we want to get to be digitally enabled to support patient care. We've done some really great stuff around sepsis and our sickest patients using Nerve Centre, which has been adopted by other trusts around the region. There are a number. So Nottingham University Hospitals also uses Nerve Centre. Sherwood Forest is using Nerve Centre in Durham. And what the four of us are doing as trusts is we are not all trying to do the same thing. So we're working on something. NUH is working on something else. And because we're both large teaching hospitals, if it works at NUH, it should work at UHL. And so, we're designing systems by clinicians to work in that way. So there's loads going on that front. But the buildings will. The technology in the buildings will support things that you are used to in your day-to-day life. So if you go to Terminal 5 at Heathrow, you check in electronically, don't you? You don't have to go and see someone to do that. That sort of technology should be available in our treatment centres. So the buildings should know. Part of my, I told you I could talk about this for hours. Part of my exec fellowship is I worked for a month at IBM as well. And the technology exists already that with your smartphone, we should be able to know that you've arrived in the building. It should automatically check you in because all of that, you've done all your booking beforehand. You've put all your information in beforehand on your phone. Your phone should then tell us you're here. You shouldn't have to come to a waiting area. You could go to the cafe and wait there, and we should be able to page you and say, right, okay, your appointment's 5 minutes away now, make your way up. That stuff all exists. It's just that we don't use it in healthcare, and that's where we need to get to with it, really.
Thanks,
if you want more, I'll keep going. But
that's really helpful, Andrew. Thanks for that. So we're in the last few minutes of today's event, and I'm conscious you'll have seen that Ian particularly is in his office today, so he's working clinically. Is there anything else in the last few minutes that people really need to ask? If you've not had the chance to ask and you still want to, you've got the opportunity to put questions in through the website. So please do. Jean, you've got your hand still up. Have we exhausted all of your questions?
Oh, sorry, I didn't know I'd got my hand
up.
No,
that's fine. That's good.
I would have, but I don't like to keep you, as I'm sure you.
So, Jean, what I suggest.
When you say you can put questions into the website, well, I tried that 2 or 3 weeks ago, but couldn't actually find a place.
Okay. So Sue, would somebody able from the comms team be able to support Jean to do that? I see Joe typing in the chat, so we might get something popping up there. Hi, Joe.
Hi, Caroline. Yeah, I mean, if Jean, what I'll send you an email, Jean, if you just want to ask any further questions directly to me, then I can make sure that they're answered.
Okay.
Yeah.
That's lovely. Thank you. Okay, so information's on the screen now about where we can where we've got more information for you on our Better Hospitals website. And like I said earlier, oh yes, we can always email be involved at leicestercityccg.nhs.uk. That's the other one. Thank you, Joe, for that. So please encourage others. If you haven't done so already, please respond to the specific questions in the questionnaire that are on the website. We really, really appreciate you feeding back to us. So I'm going to close today's event and just say thank you so much to all of you for coming. I think the questions have been really helpful to us because we see the kind of things that you're concerned about. And hopefully we've been able to respond to them in the way that you needed us to. So thank you to my colleagues for joining us, and I wish everybody a lovely Saturday afternoon. So thank you. Bye bye.
Thank you.